Hello, every morning I remind myself that progress is a journey to be cherished one step at a time. Being active and mobile instills in me a sense of freedom that is unparalleled. Rehabilitation is more than just therapy. It's about building strength both physically and mentally.
On behalf of the Board of Trustees of the Neuroaid and Research Foundation, it's my pleasure and privilege to extend a very warm welcome to our esteemed faculty, participants, IOTA, to our 7th webinar organized in collaboration with All India Occupational Therapy Association, Delhi branch, to commemorate Occupational Therapy Month and World Disability Day. NRF has found an ally and friend in the Delhi branch IOTA,
who in themselves are stalwarts of occupational therapy. Both Dr. Anita Gupta Madam and Dr. Shovan Shah Sir have been renowned international faculties and have made their presence count at many national and international stage. So I am sure that this webinar is going to be of key importance in not only in terms of learning the skills in management of cerebral palsy and related adaptations, but also to give you an exact exposure about the latest developments in the field. So once again, I congratulate one and all for organizing this workshop.
Thank you for joining us today. Let me quickly walk you through how the webinar will flow. We have 2 main sessions lined up. The session 1, it will be about ADL adaptations and assistive devices. And session 2, in this we will talk about the role of AR/VR in cerebral palsy. This session will include the introduction to technology-based tools and a case presentation to understand their real-life application. During the session, we request all the participants to type their questions in the chat box so that the speakers can present smoothly without any interruptions. It's a time for a little story. Sometime back, a very dear friend and colleague once asked me, and that question got me thinking, why are we as OTs not seeing too many children with cerebral palsy? Have the numbers fallen? Well, that was enough for us to introspect, and we figured that no, the numbers hadn't fallen. Somewhere over the years, occupational therapists have gravitated towards sensory perception domains of practice for reasons that are beyond the scope of today's webinar. And as cerebral palsy is primarily a motor function condition, fewer OTs are actually seeing children with CP and thereby not being referred as many cases as they were getting maybe 10 years back. A lot of hand splints and ADL devices or activities of daily living devices are now available over the counter. All you need to do is type in the keyword and Amazon pops up all the products. In the light of these things and the fact that very few occupational therapists are actually prescribing aids and appliances or being consulted on seating modifications, we thought of going back to our roots. Those aspects of core occupational therapy practice, which somewhere we feel are vanishing. Having said that, I would like to begin session 1 and hand over the reins to Dr. Anita Gupta, mentor and guide who is unforgettable. Well, that was personal. I'm a big fan. Dr. Anita Gupta has over 40 years of experience as an occupational therapist and retired as HOD, Department of Occupational Therapy, All India Institute of Physical Medicine and Rehab, Mumbai, which is also India's premier institution for physical medicine and rehabilitation. Her core areas of expertise include cerebral palsy rehabilitation, adaptive seating solutions, assistive and prosthetic technologies, driving and work rehabilitation for persons with disabilities.
I'm going to talk on activities of daily living adaptations and seating solutions for children with cerebral palsy. It is an occupational therapy perspective. Yeah, so if we have to understand cerebral palsy, we know that it is a permanent movement disorder appearing in early childhood. As we are told from the very beginning days of our student times, that cerebral palsy is a disability of which occurs before, during, or after birth insult. Now, if we have to look at this this cerebral palsy, I would like to walk you through the core occupational therapy framework we use when planning ADL intervention for children with cerebral palsy. Finally, we address the physical environment by checking whether there is any home modification needed, whether there is any adaptive equipment required, or there is any consideration to be given to the accessibility related problems. Sometimes a small environmental change can create a huge leap in the independence of this child. Now, these are the common assessment tools which can be used by occupational therapy professional in determining what the child's level of functioning is and whether there can be, with the intervention, whether the levels can go above or can be measured and can be the child can be showing improvement. Now, these are the common ADL challenges which one would come across when we are seeing a child with cerebral palsy. Now, if we have to see feeding, the main problem with the child is not only the oral motor dysfunction, wherein there will be a problem with lip closure or tongue thrust, or there'll be dysphagia, child is not able to swallow the type of food that is put in his mouth, but there will be problems of self-feeding which can be due to problems with the scapular instability. Child has got limited shoulder stability. So now when we have to think professionally in intervening for these children, how can we go about it? There are 5 concepts that we have to keep in mind when we are actually focusing on the ADL part of the child's functionality. Now, this is a spectrum of seating solutions that can be offered, and these are available now, thankfully, in our markets also. So you can be asking, depending upon what kind of problems the child has, what kind of home environment the child has, and what are the needs of the child. Jugaad adaptations on the right side, if you see, so there are people who are very enterprising and they try out things on their own, and they're not very wrong actually. With little intervention or little inputs from the therapist, they can make wonders and they can make the life comfortable for the child. And with the available resources, much can be achieved and there can be creativity seen in these children. So this is how the adaptations can be made with the available resources, with the available material, and in the low cost way, the child can be made independent in these areas. So this is, I think, what I wanted to convey. Thank you so much.
Thank you so much. Dr. Shovan Saha, Additional Professor at the Department of Occupational Therapy, Manipal College of Health Professionals, has a dream CV. Exceptional, to say the least. Amongst one of our senior batch of occupational therapists who did a PhD when a bachelor's was enough, Dr. Shovan was always 10 steps ahead in his game. His dedication to serve the nation when he could have easily migrated to the US is still visible as he continues to burn bright in an area of occupational therapy that still has very few takers: hand rehabilitation and splinting. He has, to his credit, 23 publications, 7 book chapters, 3 copyrights, and 5 filed patents.
Its role of functional splints and low-tech customized devices for children with cerebral palsy. So, as was mentioned by Dr. Monica at the beginning, that when we talk about occupational therapy and pediatrics, we have essentially been working in the domain of children with sensory and behavioral problem. For some reason, children with motor problem it did not receive due attention as far as the scope of practice for occupational therapy is concerned. But uh, although my area of work is traumatic hand, but maybe over the last decade, I have started to taking interest in the domain of hands with neurological problem as well, and that brings me to this subject of children with motor problem. As we know that hand is one of the most vibrant part of our body. We explore our entire environment with these pair of anatomical structures. That part of occupational therapy which is aligned to the entire practice of splinting. So if you see here, I call it as a health tunnel, and at the entry point, often it is a physician and the patient enters into this tunnel. The patient walks through this tunnel, and a host of professionals, they engage with the the individual with conditions that ultimately lead to some form of disability. And then at this exit point, the patient has to move out of this tunnel and then take a giant leap. I hope you are able to see my cursor moving on the screen. So the individual has to take a giant leap into this functional realm of the society. So when I say functional realm of the society, it basically means that the society has its untold norms of how do we need to do things. Say, for example, eating. The way we eat at home and the way it is expected to eat in a public gathering or in a restaurant, they are quite different, although eating remains the same. Say, for example, writing, it is this vacant space where the individual takes a giant leap. There is a need to refine the performance so that they can match what is required by the individual in the society. So it is this refinement, it is this process of refinement where there is a need of technology which can augment the outcome. So here, in this yellow box, there are a couple of terms. So you have movement and meaningful action, and then you have sense and perception. I'll not go into the details of these things, but just to sensitize you that these terms are the bedrock on which probably I would say occupational therapy is founded upon. And so when we get into the depth of these terminologies, then we come face to face with splints, which is today's topic. Of course, in this presentation, I will spend a little longer time. I have to, me as a creator of these devices, I have to understand that which pixel of an individual is affected because of which the individual's writing capability is compromised. Now, I might have 10 patients lined up in front of me, all of them with the same complaint that they cannot write. But for sure, the reason for each of them not able to write is very different. So, me as a professional, I need to find out that where exactly is the problem, and then we pick them up, see how we can address those problems. One is through therapy, and the other is through splint. So here you can see it is one of my personal philosophies in the field of splinting. Making a splint is no big deal, but making a change in the mind and body with a splint is a real challenge and is a big deal. So for many of us, splint is just a device. It is a piece of plastic. It is a piece of metal. But for individuals whose functions are compromised and for whom these splints have been made, they are crafted for them, they are customized for them. For them, it is something very, very personal, very symbolic. Okay, so me as a creator, me as a craftsman, I have to ensure that I instill these components, these elements into my design. Okay, then only it will be successful. Now, if you see here in this image, now this was a boy who came to me several years back, and this boy was around 14, 15-year-old boy, and he is asking this question, when will I eat? Okay, and I asked my postgraduates that what do you think? This is a question that is come from this boy, that when will he eat? He has been waiting for last 14 to 15 years. Okay, and like many OTs, my postgraduates ended up telling it will take time. Some looked confused, right? But uh, no clear answer, and the boy is not letting us go. He says that I have waited enough. Last 14 to 15 years, I have. It is my mother who has been feeding me. I need to do things myself. So that is how I put. How long will it take to reach the mouth? That is the spoon. When will the spoon reach the mouth? And if you see in the small little picture inside photograph, okay, this is just after approximately 45 minutes that the spoon is reached the mouth, right? So what has happened is a splint, a customized splint, which takes care every bit of angles that are possible. There are many things to it, okay, which is created, and then a spoon with an adaptation. The combination of those two things, in the next 45 minutes, the boy is experimenting with his newfound capability of eating by himself. So, this is how my topic is on functional splint. That means we have to design a splint through which they will be able to achieve certain level of success in their function, and then channelize those function in a more meaningful way. Okay, first it starts off with activities, and then it starts off with functions. Those are meaningful for the individual, functions that you know suits their aspirations. One of the common problem is tight ta, okay, which leads to equinus gait, walking on the toe. Okay, so you can hear, this is one of my student, after learning the craft, now she is doing it. You can see this leg and the same child. Okay, quickly take you through the adaptive device. Splints and adaptive devices are slightly different. Adaptive devices are those designs that directly will come into the function. Okay, whereas splint is more of preparing the individual to execute a function. This is the story of a young girl with infantile hemi. Infantile hemi is one of the categories of cerebral palsy. Okay, and so this girl, she has difficulty in managing hot utensils because she has no control over the opening and closing of the hand. So we trained her elbow, we trained her shoulder, okay, and then we made this device for her for the hand. Before that, we have to find out, do an analysis in the kitchen, find out what are the typical vessels that goes on the oven, for how many people they have to cook, what is the weight of the vessels. All these things are taken into account. So we found out that they have kadhai, that is one of the utensils, and it's quite familiar, right? So now, irrespective of the hand opening and closing, the person will be able to do it. And this is a saucepan, and this is how the individual performs it. So these are adaptive devices. It is quite interesting. This boy came all the way from Nigeria. One of our Nigerian students, they from their neighborhood, this boy came all the way to India, and the boy hardly interacts with anything. And then we figured it out that one of the possible things would be, can the boy start scribbling, right? And so this is his performance, and this is what we did. Now, these devices may look quite simple, but the process is quite complicated.
Session 2. Well, in 2024, when a common contact shared a number of Sparsh Mind innovations after an elaborate discussion on research topics that could have been of mutual interest, little did I know that 1 year later, we would be signing an MOU with Sparsh Mind Innovations, and almost 2 years later, our collaboration is still reinventing and innovating according to the needs of our Divyang community, especially children with special needs. Sparsh Mind Innovations was founded in 2023 following 2 years of translational research at AIIMS and IIT Delhi under the School of International Biodesign. It is a digital therapeutics company transforming brain and behavioral health through clinically validated, accessible, and scalable health technologies. Well, with Dr. Sampada S. Jahargildar, clinical mentor at Sparsh Mind Innovations and a physiotherapist by profession, we begin session 2. Dr. Sampada is an associate professor at K.R. Mangalam School of Physiotherapy and Rehabilitation Sciences, Gurgaon. Like our previous distinguished speakers, Dr. Sampada too has an impressive career profile as an educator, mentor, and guide. She is currently also the chairperson of Amar Jyoti Institutional Ethical Committee Review Board and a member of many other academic committees.
Experienced people talking about the rehabilitation in cerebral palsy, and it is my pleasure to introduce the new thing on the horizon, that is the virtual reality and augmented reality rehabilitation for our children with cerebral palsy. So I will be talking about the virtual rehabilitation using the VR and AR devices for the children with cerebral palsy. The major, the content will be like basic introduction followed with very, very little amount of, basic information on the mechanism of effectiveness. But yes, a very succinct description followed by what functional improvements we have. And then we will be further talking about the implementation considerations. So, very brief introduction. What is virtual reality for the people who are not knowing what VR is? Computer-generated immersive environment that is being provided using certain 3D devices. Basically, they help in fully surrounding the user to kind of have 3D visual sounds and interactive elements around them. So using the headsets or screens, the VR blocks out the real world and it allows the user to experience something which is actually not there, but it is a very interesting environment. So sitting here, I can imagine myself to be on a beach. But that is only imagination. But using VR, I can actually see the beach. I can see the sea. And if I just, look up, I can see the nice blue sky, the coconut trees, and so on. So basically, it creates a sense of being inside the virtual environment. So though it is the environment which is artificial, it is controlled. The fun thing is that it is repeatable and it is engaging for training, rehabilitation, education, as well as entertainment. We always have a problem with the compliance of patients. So this is an answer to that, because it is so interesting that the patient wants to go back to it to do it again and again. Coming to augmented reality. Augmented reality or AR, basically it is an emerging rehabilitation tool, again like VR. But it overlays the virtual elements into the real physical environment. So I may be seeing my own room, but on my bed I can see a tiger lying, or I can have a little cartoon sitting next to my desktop, and so on. So basically we are adding on to the real physical environment, again enabling the interactive and task oriented therapy for the individuals with CP. So what is the difference between AR and VR? Unlike VR, which immerses users in a fully digital space, AR is preserving the real world context. So within your real world, you are just having some added things which are making the activity safer and more functional and yet interesting. So the emergence and effectiveness, there are a lot of research articles which are available for those who are interested. Basically, if I just say that VR has been one of the most studied rehabilitation tools, and it has been found to be having significant improvements across multiple functional domains for the children with cerebral palsy, especially when they were compared to the conventional interventions. Though I will say that these research studies talk about comparison between conventional interventions. What we will as we go further ahead in the presentation, we will be talking about supplementing VR and AR with the conventional interventions to make it most effective. So on the whole, the researches point towards a good amount of effectiveness of AR and VR devices, especially the VR devices, and that too for the upper limb activity. So solving our functional ADL problems and trunk. So when we talk about trunk and upper limb, a lot of ADLs, I think all are my, occupational therapy, professionals would understand how important these two things are, and also they are so difficult to manage through conventional methods. So I have tried to explain the mechanism of effectiveness so that the parents who are there with us also understand it in very simple words. So, AR and VR devices give an opportunity for participation in a game-like situation. So, when there is a game, it is always very interesting, it is adequately challenging, and because of the immersive environment, the patient feels that he is a part of the whole setup which is provided by the VR. And because of the game, the patient is engaged into practicing the motor skill again and again. And because of these high intensity repetitions, basically, when we talk about teaching movement, we always emphasize a lot of repetition so that it becomes so inculcated in our automated processes that we are not thinking when we are doing any activity. This is also a data driven intervention, and while it is also human centric, and because of this, we will be having better rehabilitation outcomes in multiple domains. So here we are at Sparsh Mind Innovations. Basically, it was founded in 2023, and it provides effective neuro solutions for cognitive and physical recovery of individuals with neurodivergent conditions. So the device has also been successfully used with stroke patients, and we strive to improve the quality for individuals worldwide, and ultimately advancing towards better neuro rehabilitation.
ये कितने का होता है? 100. Very good. ये वाला 200. और ये वाला 10. अच्छा, तो मुझे गिन के बताना. ये वाला, हाँ, तो अब ये दोनों मिला लेंगे तो कितने हो गए? कितने पैसे हैं? वेरी गुड. 30. दीदी का नाम क्या है? लिखो फिर. लाइन के अंदर लिखना था.
लाइन के अंदर लिख रहा हूँ.
रीमा. अरे दीदी का नाम भी बहुत अच्छा है, राहुल एंड रीमा. और मम्मी का नाम? राम कुमारी. रमा. राम कुमारी.
बॉल कितनी बॉल? बॉल को पंच करना ऐसे. कौन से हाथ से? ऐसे. Which hand?
Left. हो गया.
वाओ, कुछ पता चला राहुल को?
राहुल, दोबारा देखो बॉल, हमें ये रही सामने बॉल रही ना, इसको टच करो.
आपके राइट हैंड में कलर्स भी हैं, आपके राइट हैंड की फिंगर्स में कलर्स हैं, देखो डिफरेंट डिफरेंट कलर्स की तरफ देखो। आपकी लेफ्ट फिंगर्स में भी हैं, है ना। अभी देखो सामने पियानो है, पियानो को टच करना है, हाथ उठा के ऐसे टच करो, ऐसे ऐसे टच करना है बस। ऊपर है काफी, इसे नीचे कर दें, अभी कर देता हूं। चिन अप है। कौन सी एक्टिविटी बहुत अच्छी लगी? कौन सी एक्टिविटी फेवरेट है? अभी हमने कितनी 5 एक्टिविटीज की हैं, कौन सी सबसे अच्छी थी? लास्ट वाली, मैंगो वाली? बताओ कौन सी एक्टिविटी अच्छी? मैंगो एक्टिविटी अच्छी लगी है आपको? लास्ट वाली?
लास्ट वाली
अच्छी लगी?
लास्ट वाली।
और प्लांट वाली एक्टिविटी नहीं पसंद आई? वो गंदी है। बॉल पंच एक्टिविटी वो अच्छी है। और कौन सी अच्छी लगी? लास्ट वाली, ओके।
ठीक है, एक लास्ट वाली करेंगे फिर छुट्टी होगी। ठीक है। इसको पहन के कैसा लगे आपको?
कैसा लगा इसे पहन के?
अच्छा है।
अच्छा है, अच्छा लगा। थकावट नहीं हुई? थक गए? नहीं।
टाइट वगैरह तो नहीं था कहीं पे?
नहीं।
गुड, ये तो बहुत ब्रेव बॉय है ना? वेरी नाइस।
दोबारा करें?
क्या?
दोबारा करें?
अच्छे से नहीं लगा।
अच्छे से नहीं लगा। वेट एक और बार, दोबारा एक और बार ट्राई करते हैं। वेरी गुड।
अच्छा, लेफ्ट हैंड से करो, छूने की कोशिश करो। वेरी गुड। अब उसको पकड़ने की कोशिश करो, हाथ ऊपर उठाओ, ज्यादा लेफ्ट हैंड यूज करता है। राहुल, राइट हैंड से इससे छूने की कोशिश करो। अच्छा, मैं थोड़ा पास लेके आ रही हूँ।
जिस हाथ में ज्यादा ताकत है वो हमें ऊपर की तरफ उठाना है ना, जितना उठे उतना।
राहुल के भी हाथ।
हाँ, लेके जाओ प्लांट के पास। हाँ, दोबारा ट्राई करो। सही कर रहे हो आप, दोबारा ट्राई करो।
So now so Rahul's case is open for panel discussion. As you can see, he's a 15-year-old child with dyskinetic cerebral palsy, completely independent in the sense that he can read, he can write, as well as even make a phone call using his toes. He uses the computer with his feet, but his upper extremity is practically non-functional. Right hand is non-functional completely, and his parents are mostly concerned about his activities of daily living because he is not able to eat. He can mix the food with his feet, but he is not able to take the spoon to his mouth, and he's not able to do his basic self-care activities such as bathing or dressing or cleaning up after the washroom activities, etc. Dr. Anita, Dr. Shovan, Dr. Sampada, it's all yours. What do you suggest? How should we go about this managing the child?
When I have seen the video, I feel it is more of a motor driven disability rather than a cognitive driven limitation. He has a good amount of motivation and he's attending mainstream school. So these are all the positive findings in him. So from our perspective, I feel we should think that the aim should be to make him enable rather than normalize him. The entire therapy should not focus on normalizing him, making him use his hand to the best possible extent, rather than try and be task specific. What tasks he needs to be mastering, he is going to be needing. We have to work upon improving and making him efficient in those tasks. Like for example, if he is writing with his feet, with his toes, it should be continued like that. We should not force him to stop writing with his toes and try and see whether he can write using an adaptive device with his hand. That is going to becoming more hindrance for him. In certain activities, you may have to try out with some kind of techniques wherein we can, like, weighted cups or suction cups for eating. For example, if you can use a wet towel under his plate or a suction cup kind of a thing, and see whether that allows him to stabilize his objects in front of him, and he is able to stabilize him by giving a good support while sitting. His proximal girdle is given a good control, shoulder girdle. If it is given a good sort of stability, then whether he is able to use his distal extremity for functioning. So these kind of things you have to target.
Yeah, I also had seen the video and I saw it. I always look at things from the prism of splints. First, we should try him to do simpler tasks. When I say task means it will involve a lot of experimentation. Okay, and to be able to see how the individual can perform bilaterally coordinated task at a very gross level. So, and in the process, we also understand that at which joint, if we stabilize, how does the proximal joint behave? How does the distal joint behave? Say, for example, basically what happens to demystify certain things. The individual has definitely certain lack of control. Okay. And when the individual has lack of control and with that limited ability, the individual has to control multiple joints. So if you see upper extremity, right from shoulder, elbow, forearm, wrist, multiple finger joints. So when the resources are very limited and then we have to use it over a number of elements, that can become a challenge. It will add to the problem. Right. So through Splint, what we do is we try to analyze this and find out that which joint, if we stabilize, when we are saying that we stabilize with a splint, basically what happens is the limited control then does not have to contribute on that joint. So the other joints, they get a bigger chunk of the control. These are very simple mathematics with which we work.
What needs to be done is that we need to stick on to our very basics of the treatment and embrace the new which is coming in. And we always, as clinicians, we have to have our discretion when to use what. Without a proper trunk stability, I cannot expect the child to do any kind of movement. I have seen the minute you stabilize the trunk, the hand goes up without a splint, without any special device. So that is the beauty. Yes, food for thought. Lot of things happening in the in the country these days, coming from other global places as well. So I think people should think about it, and we should go ahead with what we have and use the new. Thank you.
So coming to the question answers, we've got a huge number of question answers. It's going to be extremely difficult for me to to take up everything. I would like at least five people from the audience to raise their hands so that we can call upon them and they can ask their questions directly to our panelists. The rest of the questions we have with us, we will be taking care of that. But if somebody five questions we can take. So please raise your hand and unmute yourself.
I'm Ved Rajput. I'm working in the field of cerebral palsy since 16 years at Prayagraj. I have a question related with dyskinetic cerebral palsy. According to your opinion, ma'am, what is the best treatment for the people with dyskinetic cerebral palsy, and how can we maintain their posture alignment, and how can we prevent involuntary movement, or how can we provoke their involuntary movement?
See, basically, when we are talking about the intervention, the pharmaceutical intervention will be taken care by the medical practitioner. If there are any drugs or any kind of injectables which can be given and whether they have an effect, you have to try it out that. But otherwise, from therapeutic point of view, you have to try seeing whether weighted cuffs work for this child or not, for the dyskinetic kind of cerebral palsy. You have to see whether there is a possibility of facilitation of extension pattern for the child, and whether you are able to work upon rhythmic stabilization. That these are the approaches, that these are the concepts that we really take care of when we are talking about dyskinetic CP management, and basically you have to work upon functional training for the child, so everything put in together, the weighted cuff, the use of weighted jackets and postural stabilization, all of this when you are attempting, the entire goal is to work upon the functional achievements, not on the normalization of a movement or of tone, but to see whether functionally, if the child desires to reach out to a certain thing, bring it closer to him, take it away from him, move it in the space, then whether those kind of movements are possible for him to achieve his functional goals, as we have mentioned, writing or striking a carom striker while he's playing, some kind of games activity or some kind of board activities or some kind of your social media activities, the game, the VR and these kind of things, whether he is able to achieve these. So basically it will be functionally oriented, but your therapy focus can be through these mediums of weight bearing, facilitation of extensor pattern or rhythmic stabilization. All of these concepts you will have to put into effort to see whether that materializes with the involuntary movements and the dyskinesia.
Thank you, ma'am. Thank you so much. So if there are any further questions, we would be willing to take them on later. We do have a team at NRF also who will be able to help you on these aspects. So please do stay in touch. Priyanshi Raj's parent mother has been wanting to ask a question.
Yes, ma'am. My sister child 8 years old, but वो सिटिंग नहीं कर रही है, but body में बहुत ज्यादा उसका वाइब्रेट है.
So, ma'am, she also has dyskinetic CP, and yeah.
So, आपने आपकी बेटी के लिए स्पेशल सीटिंग अरेंजमेंट कुछ किया है, कोई चेयर मॉडिफाइड वाली लिया है?
यस मैम, चेयर में ली हूँ.
उसके अंदर स्ट्रैप्स वगैरह लगाकर वो बैठ पाती है बहुत देर तक?
बहुत देर तक नहीं बैठ पाती है, बट वो ज्यादा हिलने लगती है, हिलने की वजह से वो थोड़ा कभी कभी गिर भी जाती है।
कोशिश सारे उन्होंने की है।
हाँ, तो आपका चेयर जो है ना वो ठीक करा, मतलब ठीक ऐसे होना चाहिए कि उसको सपोर्ट अच्छी तरह से मिल सके उसमें। और जब वो बैठती है तभी पैर भी उसके
पैर भी
मतलब
ऊपर खींचती है। हाँ, पैर हाथ दोनों ऊपर खींचते रहती है, और बार बार टंग को बाहर करती है,
हाँ हाँ
और लार
तो
बहुत ज्यादा निकलता है।
ये जो डिस्काइनेटिक हम लोग जो बोल रहे हैं ना, उसमें ये सब देखा गया है, ये सब होता है इसमें। आप इसका थेरेपी कंटिन्यू कीजिए, और जो स्पेशल अडेप्टेशंस है, जैसे जो चेयर है ना, उसमें जो जो कुछ मतलब जो कुछ भी इसमें लगाने की जरूरत है, मैं मोनिका मैम से बात करूंगी, तो वो आपको मैसेज देंगी कि किस तरह से उसमें तब्दीली की जा सकती है, ताकि उसको बैठने में थोड़ी आसानी हो सके।
यस मैम।
थैंक यू अनीता मैम। एनीबडी एल्स?
मैं बोमरा राजस्थान से बात कर रहा हूँ मैम।
हाँ जी, प्लीज बोलिए। यस यस।
मैं आपसे बहुत पहले जुड़ा था, और अभी बच्चा वो कुर्सी पे अच्छे से बैठ पाता है,
हाँ,
पर एक्चुअल में प्रॉब्लम क्या है कि वो बैठ नहीं पाता, पैरों की बहुत ज्यादा दिक्कतें आ रही है उसको।
I'm again dyskinetic.
Dyskinetic, or this is adaptive spasticity?
No, dyskinetic completely. So
I think that has to be taken care of with strapping, proper strapping. The 90-90-90 angle, you have to work upon that, so that the feet are also strapped properly.
Yes.
And the under surface of the lap tray, the cutout board that we give, make sure that that is also padded well, and there is no rough edge, rough surface there, So basically, when they are banging their leg, the knee hits on the under surface of the lap tray, generally there is an injury. So you have to make sure that that part is softened for them.
Okay,
आप लोग इसके बाद कांटेक्ट करिएगा। आप लोग माने आप आए थे और उसके बाद फिर फॉलो अप नहीं हो पाया है, तो आप जरूर हमें दोबारा कांटेक्ट करिएगा, क्योंकि काफी चीजों का फॉलो अप करना बहुत जरूरी है। एट दिस पॉइंट ऑफ टाइम आई वुड आल्सो लाइक टू टेल ऑल द पार्टिसिपेंट्स, स्पेशली द पेरेंट्स, दैट आप फॉलो अप बहुत जरूरी है, क्योंकि अगर आप एक बार सीख के चले जाते हैं और फिर फॉलो अप नहीं कर पाते हैं, तो बच्चे की ग्रोथ के साथ जो डेवलपमेंट होती है उसको मॉडिफाई करना टाइम टू टाइम बहुत जरूरी है। तो माने एक बार में अगर आपको कुछ बताया जाता है तो वो सिर्फ उसी टाइम के लिए होता है। आगे जैसे बच्चा बड़ा होता जाता है, उसकी नीड्स बढ़ती हैं, तो चीजों को मॉडिफाई करना पड़ता है। So as a professional, this is what I would like to advise all our parents. Please keep in touch with whoever you are going for therapy, so that जो भी चीजें आपको modify करनी होती हैं वो आप कर पाते हैं। So please get in touch with us. प्रियांशी की mother, स्वरूप के father, please प्रवीण जी आप भी आइएगा जरूर, और हम लोग बताएंगे कि कैसे आज की स्थिति में आपके बच्चे को और क्या जरूरत है वो हम बता पाएंगे। Anybody else? Any student? Any professional?
Okay, ma'am. Thank you.
Hello, ma'am. I'm Rahul's sister.
Yes.
Actually, the main problem that we are facing in Rahul's case is the stiffness in hands. So, can you just tell me what we can do for that?
Rima, we'll be working out your program. तो बेसिकली राहुल के लिए तो पूरा शुरू से ही करना पड़ेगा, क्योंकि काफी टाइम से कुछ हुआ नहीं है ज्यादा, और वो प्रोग्राम हम वर्कआउट करेंगे। सो मैम, इज देयर एनीथिंग स्पेशली यू वांट द पेरेंट टू डू एट होम? शी इज लॉट ऑफ Rahul is the child whom we just saw, so that's his sister. So she's saying there's a lot of tightness in his hand, upper extremity. So so she's having a problem with that. So we did advise for splints, but because we don't make.
Just check with the physician whether Botox will work for him.
Acetane is going on right now. So
Acetane is going on.
Acetane just started.
हम बैक्लोफिन भी स्टार्ट कर दिया है।
बैक्लोफिन किया है स्टार्ट?
यस मैम।
तो उससे कम हुआ होगा ना उसका?
मैम अभी तो नॉर्मली है, उतना ही चल रहा है।
कितना दिन हुआ है बैक्लोफिन लेकर अभी?
मैम अराउंड 1 मंथ होने वाला है।
अच्छा, मेरे ख्याल से थोड़ा दिन देखिए, बैक्लोफिन से कम होता है।
हाँ
बैक्लोफेन से थोड़ा कम होगा, 3 महीने लेगा ना तो थोड़ा फर्क दिखेगा.
ओके मैम,
Involuntary
बिकॉज
movements उससे कम
स्टिफनेस
होंगी.
कम होगा तभी तो वॉलेंटरी मूवमेंट्स भी
Correct.
वो कर पाएगा.
Correct.
जी.
Correct.
जी.
So we've just started working up with Rahul, and a lot
Yeah.
of things have just started. So
Yeah. Just try and see whether weight bearing exercises work for him or not. No,
Yes,
all
ma'am.
4 weight bearing and weight
Yeah.
bearing on the upper extremities, more focusing on that anterior
Yes.
posterior shift and lateral shifts, and whether all those things work for him.
Yes, ma'am. Yes, ma'am.
Yeah.
Any
And
student or professional? Yeah. Sorry, ma'am. Yeah.
try out with weighted things also. Weighted cuffs
Yes.
for him.
ma'am. Yes, ma'am. Any other student or professional who would like to ask a technical question?
Ma'am, I want to ask that what therapy is much better for CP child? Like it is constant induced therapy, or we can use only the compensatory therapies, like you are doing with the same Rahul. But it would be more better if we use constant induced therapy rather than compensatory techniques. So I just want to ask only this.
Well, there is no
Rahul is a
one
little
answer
older.
to this question.
Yeah. And Rahul is also much older. He's much older, so he's at that stage where independence is a priority. So at every stage of life, priorities are different.
Yeah, no, basically you have to really, you can't say that ek dawa sabko kaam karegi, it's not that. You have to have a mix of everything. At some point you may have to use compensatory strategies. At some point you will want to restore the function. At some points you will want to use adaptive techniques. So it is not one answer to everything. You may have to work, and with Rahul also, it is just not that you switch over to the AR VR and everything else is put to stop. It is not that. You may have to continue using the rhythmic stabilization, weight bearing, and you will have to continue with the baclofen for some time. See, these are all, and if that doesn't happen, it will lead to secondary problems with him. There will be contractures, there will be set deformities which will take place in the upper extremities also. He had constant movement of the wrist, the fisting of the hand, thumb and palm. So all this is going to lead to arthritic changes later in life. So it is an ongoing process. It is not that you stop here and it is the end of the treatment. Understood? And as you said, compensatory and the complementary treatments also, they will go hand in hand. Am I clear?
Yes, ma'am. Thank you.
Dr. Shobhan, I'd like to ask you a question which has come. What are some typical challenges of splinting that you face while you're dealing with patients? What are the typical challenges that you come across? Is it the attitude? Is it the resistance? Is it the fear? What is it?
Yeah. So, from my personal experience of practicing splinting, there are compliance issues. There are individuals giving importance to splint because many a times, if a doctor is not prescribed, then for them to accept a splint is often that is a big struggle to negotiate. Then financial considerations, that also is another factor. If they are not seeing any reasonable outcomes, then their belief in the system that gets affected. Cosmesis is another concern. So these are some of the concerns which any practitioner in this domain, they have to keep that in mind and make conscious effort to negotiate these challenges. There are ways to deal with them, but these are some of the technical challenges. But most importantly is the innate skill, the professional skill that is required to make splint. That definitely is a requirement.
So, in your experience, when you feel that somebody requires a splint, and the kind of splint that you're prescribing, if it's a functional splint or there are three, it's either a static or a resting splint or a functional splint or a dynamic splint. Every splint will have its own applications and a cost to it. So if you feel that a parent is not able to afford that particular cost, do you also explore low materials available in the in the environment or do you insist on just working with thermoplastic, or can we fabricate something out of wood?
So over the years of practice, we had developed certain skills, of negotiation. These are very different kind of negotiation. One of the, just to make a quick point on that, we try to figure it out that what splint and what will be the quantum of improvement that we can produce. Now, these are very intense judgment that are required, because often what happens is, supposing there could be a patient traveling from Chennai to Manipal. Now we are discussing over the telephone. We have had access to certain visuals. Now we have to make sure that when we are discussing about splint and the problems and the outcome, we are quite spot on our judgments. So that is why the patient will travel this distance to avail the splinting facility. Okay, so we do have to have these correctness, and then it gets sold. Yes, at our facility we have metal splints and plastic splints. Of course, we don't make it of wood, but metal and plastic. And if somebody is not affording a plastic splint, then the obvious this thing will be metal. But it is not only the cost as a factor. There are many indications, contraindications. There are prescriptions, and of course the kind of condition that the individual is having and what do you want to achieve. So based on that, material choice are being made. So there are many factors, actually. There are many factors, and there's a whole lot of negotiation that happens.
Thank you so much. I will not be able to take any more questions. I am very sorry for that. However, all the questions, the community group is going to be still active. You can put in your questions and we will definitely get back to you.
So we have shared the quiz and the feedback form link in the chat box. It is mandatory to fill and submit it within 24 hours to get your e-certificates. And rest, as ma'am said, you can share your questions in the community group, and we'll share it with the experts and they will get back to you.
As we formally conclude today's webinar, it is both an honor and a privilege to extend the vote of thanks on behalf of the Neuroaid and Research Foundation. Our sincere gratitude to Dr. Lalit Narayan, President, Delhi Branch IOTA, and co-convener Dr. Neeraj Mishra for their consistent support and collaboration in the organization of this event. Your partnership has been invaluable, and we will remain deeply appreciative of your contributions to the advancement of occupational therapy. We convey our sincere thanks to our distinguished speakers, Dr. Anita Gupta, Dr. Shobhan Saha, and Dr. Sampata Jahagidar. Your scholarly insights, clinical expertise, and thoughtful deliberations have greatly enriched today's discourse. We also extend our appreciation to our AR/VR partners, Sparshmind Innovations, CEO Mr. Harikrishnan Mohanan, Directors and CTO Mr. Abhijit Unni, and Dr. Arohan for their continuous support, enthusiastic participation, and insights on progressive perspectives on the integration of technology within therapeutic practice. Our heartfelt acknowledgement goes out to the Nai Disha Foundation for graciously disseminating the webinar information within their parent community. Your support has enabled us to reach families and caregivers who directly benefit from such knowledge-sharing initiatives. We express our deep gratitude for all the logistic and technical support provided for the webinar by the Indraprastha Apollo Hospitals. We are thankful to the Board of Trustees, NRF, for their continuous guidance and stewardship. Our sincere thanks to the entire NRF team whose diligence and coordinated efforts ensured the smooth execution of this program. A special thank you to the organizing committee comprising Mika Mittal, Child Guidance Counselor, Dr. Nidhi Kashyap, Dr. Nidhi Gautam, and Dr. Shalini Singh, Senior Physiotherapist, for their significant contribution backstage to ensure that the webinar went off as well as we hope it did. A big thank you to Rahul, our child, and his family members for their consent and cooperation towards the webinar. Finally, we acknowledge all participants, therapists, educators, students, parents, and caregivers for your active engagement, thoughtful questions, and gracious presence. Your participation reaffirms the importance of continued learning and collaboration within our professional community.
And a very special thank you to Dr. Monica Srivastav for putting this together. Thank you, all the speakers, all participants. Thanks a lot.
Thank you so much, ma'am and Shovan, for agreeing to do this. A lot of people joined because of your presence.